Next speaker is Dr. Noah Kornblum. He's an assistant professor of medicine at Albert Einstein College of Medicine and also an attending physician at Montefiore Einstein Center for Cancer Care. He will present the PrECOG 0102 clinical trial randomized double-blind phase 2 trial of fulvestrant plus everolimus or placebo in postmenopausal women with hormone receptor positive, HER2 negative metastatic breast cancer resistant to aromatase inhibitor therapy.
Good morning, everybody. Thank you. I'm so grateful to be here to present our results on behalf of all the investigators and individuals involved in PrECOG 0102. As was said, it's a randomized double-blind phase 2 trial of fulvestrant with everolimus or placebo for the treatment of hormone receptor positive HER2 negative metastatic breast cancer, which is resistant to aromatase inhibitor therapy. A little bit of background. While aromatase inhibitor therapy is highly effective treatment for hormone receptor positive metastatic breast cancer, resistance to AI therapy ultimately develops in most patients. One strategy for addressing AI resistance is by targeting the PI3 kinase AKT-mTOR pathway. For example, combining the mTOR inhibitor everolimus with the steroidal aromatase inhibitor exemestane significantly improved median PFS from 3.2 to 7.8 months in the phase 3 Bolero-2 trial, and this combination is currently approved for use. Another strategy for overcoming AI resistance is by more completely blocking estrogen receptor signaling through use of a selective estrogen receptor downregulator, such as fulvestrant, which may result in more complete blockade of the ER signaling pathway than a steroidal AI, such as exemestane. And so our hypothesis is that the combination of everolimus and fulvestrant would be more effective than fulvestrant alone in AI-resistant disease. The key eligibility criteria for study participation are listed here and included post-menopausal women, hormone receptor positive, HER2 negative, inoperably locally advanced or metastatic breast cancer, AI-resistant disease, which was defined as relapse while receiving adjuvant AI therapy or progression after one or more AIs for metastatic disease, ECOG performance status 0 or 1, normal organ function. Patients were allowed no more than one prior chemotherapy regimen for metastatic disease, measurable and or non-measurable disease by RECIST 1.1 criteria, and of note, 2 doses of fulvestrant were permitted within 28 days prior to randomization. The study schema is shown here. Patients were stratified by ECOG performance status, presence of measurable disease, and prior chemotherapy status. They were then randomized 1-to-1 for treatment with high-dose fulvestrant with either everolimus or matching placebo. In the induction phase of the study, patients received their assigned treatments until evidence of progression of disease or unacceptable toxicity for a maximum of 12 cycles. Patients who did not experience progression or unacceptable toxicity were unblinded and allowed to proceed to the continuation phase of the study and remain on fulvestrant with or without everolimus. Tumor measurements were performed every 12 weeks, and of note, corticosteroid mouthwash prophylaxis was not used. The statistical design employed is described here. The primary endpoint of the trial is progression-free survival as assessed by the local treating physician. We calculated a sample size of 130 total patients would be required for the study to have a 90% power using a one-sided type 1 error of 10% to detect a 70% improvement in median PFS from 5.4 to 9.2 months. Comparison was made by stratified log rank test, and an intention to treat analysis including all randomized patients was performed. We estimated that full information would be available after 98 events, which was death or progression. And I don't have all the information for you today, but you should know 131 patients were actually randomized, but only 130 were treated in this study. So as far as the results, here we see the Kaplan-Meier curve of progression-free survival as assessed by the treating physician, which is the primary study endpoint. There were 101 events at the time of an analysis, which exceeded the minimum of 98 events required to trigger this analysis. The addition of everolimus improved median PFS from 5.1 to 10.4 months. The hazard ratio for PFS was 0.60, favoring the everolimus arm, with 95% confidence intervals of 0.40 to 0.92. The stratified log rank p-value was 0.02, indicating that the primary trial endpoint was met. That did not show well on the slides, so you can draw the lines, I think. As means of a little conclusion, we found that the addition of everolimus to fulvestrant improved progression-free survival from a median PFS of 5.1 months to 10.4 months for the combination, which was associated with a hazard ratio of 0.60 and a corresponding p-value of 0.02. The combination of fulvestrant and everolimus was associated with more toxicity, which included a higher grade 3 adverse event rate of 48% compared to 14% for the fulvestrant alone arm. The most common grade 3 adverse events occurring in more than 5% included stomatitis, 9%, pneumonitis, 6%, fatigue, 5%, and hyperglycemia, 6%. This toxicity profile is consistent with the everolimus arm in the Bolero 2 trial. And again, of note, prophylactic corticosteroid mouthwash was not used in our trial, which has been shown to reduce the risk of grade 1-2 stomatitis from about 65% to 20%. So we feel this study provides additional evidence that adding everolimus to anti-estrogen therapy in AI-resistant disease improves clinical outcomes. Thank you.
Thank you.
Okay, if we move on to questions, we have two options to make everybody happy today. Line up at the microphone to ask a question. If you want to write, I have an extra microphone here that I can provide to you to write and ask questions at the same time. Just raise your hand, I'll tell you, okay?
And let me start with the first question, Dr. Kornblum. Given the fact that we do use exemestane and everolimus as a standard therapy in metastatic breast cancer, how do you see the results of your study changing that?
I think that's a great question, and others have been asking me that. I think our study provides an additional option. There are some potential advantages of fulvestrant in some people's mind over a steroidal AI such as exemestane. I think there's some evidence mechanistically that there may be some advantages. We don't really have a direct comparison of these two combinations, but I think it does offer some options, and it's nice to have greater options, particularly AI have some concerns with women who have bone health issues and other things, so we may be able to now have an additional choice for women, where we could tailor it to some specific clinical characteristics. There are other answers to that, but I think that would start.
Perfect. Yes,
Hi.
please.
Caroline Helwig, ASCO Post. It's a similar question, but I was wondering if the populations of Bolero in your study were very different, because your control arm and your experimental arm had longer PFS than both of those things in Bolero. So I just wondered, are they the exact same population?
Yeah, these were the same populations. I think my opinion why our PFS is longer in the placebo arm is because I think fulvestrant is a more active drug than exemestane when given at higher doses. We used, I didn't speak to this today, but fulvestrant dosing has been optimized at 500 milligrams day 1, day 14, and then monthly on day 1 of a 28-day cycle. And many of us believe that there may be slight superiority to fulvestrant in the AI-resistant cohorts than a steroidal AI like exemestane. So I think that we're seeing slightly better numbers. Again, that's an opinion. These are not direct comparative numbers that I can provide to you.
Yeah, Marisa Weiss, breastcancer.org. Do we have any sort of patient-reported outcomes to have a better understanding of how people weathered the storm of the combined therapies? Because there was a significant, the combined arm, that there was a significant amount of daily multiple side effects. Were those side effects clustered into people? Was it about 10% of people had most of them, and then 90% were pretty clear, or what was the distribution of those side effects, and how would the patients themselves sort of assess the value of the extra benefit of the combined arm given the price they had to pay?
Thank you for that question. It's a hard one to answer because I don't think I really have all the full information from our particular study in terms of reviewing all the case reports. It is true that study participants did experience more than one toxicity. When we provide these adverse event numbers, we're generally giving the worst grade toxicities that people experience. But for example, it is not uncommon to experience low grade stomatitis, oral mucositis, mucositis and fatigue, for example. And I think we are all learning in general, on the fly somewhat, how to manage the safety and toxicity profiles for these combinations, particularly the clinicians that are using exemestane and Afinitor combinations, everolimus exemestane. I alluded to the prophylactic steroid mouthwash, for example. That information and utility was not known at the inception and conduct of this study, but now I think it's an example of where early recognition of toxicities and vigilance in terms of clinician awareness, patient education, and really frequent assessments can help us mitigate and manage. So I don't have a really direct good answer for your question. I think there are combined toxicities, and we are trying to help people. I think on balance, and my experience is that the benefit is outweighing the cost, so to speak, to use your language.
And this is an extremely important point because we have adjuvant clinical trials ongoing with everolimus. And so when you're asking a woman to be on this drug for a year, having to deal with stomatitis is extremely important. Now, I do have to say, clinically, when you do use the mouthwash, the incidence of stomatitis is minimized. And our patients are able to tolerate it both in the metastatic and the adjuvant setting. The more we use these drugs that are very tricky, the better we become at dealing with the side effects. And I've seen in the past couple of years our patients tolerating them much, much better than they used to, probably because of our experience.
One question here.
Noah, very nice. It's not surprising that this worked, since the first everolimus paper in people was with everolimus and tamoxifen, and it doubled PFS there. Fulvestrant is just a super tamoxifen. Were any of your patients previously treated with either fulvestrant or with everolimus? If they were, that would be very interesting. So we know everolimus works, but none of us has an idea of how to use it. We don't know when to start, and we don't know when to stop. And we really don't know what to give it with.
I think those are great points. None of our patients received prior everolimus. That was a restriction in the study. But you were allowed to have 2 prior doses, and that was just a simplicity thing. Some patients were, clinicians wanted to start their patients and then go on. But your point is well taken. I'm not sure. I think, particularly I didn't allude to it today, but I will in the big talk in a little bit about the CDK4/6 inhibitors. So now we have another novel combination that seems to offer real benefit in endocrine-resistant disease, and so how we're going to learn to sequence these drugs, which should come first or after. I had questions about whether patients in this study had prior CDK4/6 inhibitor therapy. There were only 2 patients in this study that did receive CDK4/6 inhibitors prior, and they were both in the placebo arm. But this study was written and conceived before the availability of those medicines. It'll be very interesting to see what will fall out with that. Those medications appear to be beneficial both in first line when combined with AIs and second line, with fulvestrant. So we'll see. It seems like the frontline mTOR inhibitor therapy, particularly it was with temsirolimus, was negative. So we're going to have to wait and see how to sequence these drugs, I think.
Okay, go ahead, Nick. Last question.
So can we quote Dr. Vogel now that he's a member of the press? What's next for this combination? Do you have to go to phase 3? Is there an application in with the FDA with this data? I mean, or will there be? What can we expect?
I can't speak to the application. I think you'll have to direct that to the pharmaceutical company. I think that our results are encouraging. I'm always, cautioning myself to have, irrational excitement when we see new combinations show benefit, but I think it's going to be real in my opinion. It looks like it's consistent with other findings that we're seeing in combinations both with Afinitor and other drugs. And so, to speak to what was said a little bit earlier, these pathways are complex, and there's feedback that's happening between PI3 kinase and AKT and mTOR, and the rapalogs of everolimus is a rapalog only inhibit TORC1. We now have dual mTOR inhibitors in various stages of clinical trials. So I think this is a very, very active area of clinical research right now. We're going to see a lot of things falling out in the next years, and so my personal opinion is because this is likely to become a good treatment option for women, but just how that will shake out in terms of whether the company will seek, formal approval, I can't speak to that.
So there's not a phase 3 trial that started. This is what it is, right?
In my awareness right now, there is not, although there are other phase 2, multi-arm phase 2s going on right now, including our combination, fulvestrant and everolimus, with other combinations. AstraZeneca has a dual mTOR inhibitor with a 4-arm trial ongoing right now, looking at 2 doses of a dual AstraZeneca mTOR inhibitor, TORC1, TORC2 inhibitor at various doses with fulvestrant versus everolimus and fulvestrant alone with placebo. So that'll provide additional information. And there are other ongoing similar studies, but I'm not aware of a phase 3 planned at this moment.
What is important for clinicians is that when we use combinations with our patients, that there has been some sort of clinical trial that has validated that combination. And what this clinical trial tells us is that we can use fulvestrant with everolimus clinically. When a patient has been on an aromatase inhibitor and we don't want to use another aromatase inhibitor right after that, being able to have the freedom to use fulvestrant with everolimus is extremely important in clinic. And it seems that at least for CDK4/6 inhibitors and for everolimus, the sort of endocrine therapy that you pair them with is not as important as the fact that you use the drugs. But for us to gain that understanding, we needed trials like this one to show that to us.
Thank you very much, Dr. Kornblum.
Thanks,
Dr. Katamani, we're ready for the next.